My name is Seth K from the Center for Thyroid and Parathyroid Surgery, and in this video we will be discussing well differentiated thyroid cancers. Well differentiated thyroid cancers encompass over 90% of all thyroid cancers and include papillary thyroid cancer, follicular thyroid cancer, and oncocytic cell carcinoma, previously referred to as Hürthle cell carcinoma. We do not know how or why thyroid cancers develop, and it's usually not the fault of the patient. You do have a slightly increased risk of having or developing thyroid cancer if you have a first-degree relative with thyroid cancer. That includes mother, father, sister, brother, or son, daughter, or if you're exposed to radiation, radiation in the head or neck region, particularly in your childhood. Once we make a diagnosis of well-differentiated thyroid cancer, one of our first goals is to rule out spread of that cancer. The most likely place where this cancer would spread to would be to the lymph nodes in the neck. The best way to rule that out is to look with a combination of ultrasound and CAT scan your neck. If there are any concerning appearing lymph nodes on ultrasound or CAT scan, they would require a fine needle aspiration or a biopsy to rule out spread of cancer to that lymph node. If you are younger than 55 years of age, you more than likely have a stage 1 cancer. The only thing that makes you have a stage 2 cancer if you're younger than 55 is if your cancer is spread beyond the neck to elsewhere in your body. If you're older than 55 years old, you are a stage 1 cancer if your cancer is confined to the thyroid. If it has spread to a lymph node, you're more than likely a stage 2 cancer. If it's starting to invade some of the nearby important structures of the neck, it would be stage 3. If it is spread beyond the neck, it would be stage 4. We measure prognosis, or how well someone does with treatment for thyroid cancer, well-differentiated thyroid cancers, with something called a 10-year survival rate. How many patients are still alive 10 years following their treatment and have not died from this cancer? For stage 1, the 10-year survival rate is nearly 100%. For stage 2, it ranges from 85 to 95%. So even with the stage 2 cancer, your prognosis is still excellent. There are 3 different ways that we treat well-differentiated thyroid cancer. Number 1 is surgery. If your cancer is spread to a lymph node, you will require a total thyroidectomy and a neck dissection in the compartments where those lymph nodes have spread to. In the central neck compartment between the carotid artery and the trachea, it's called a central neck dissection. To the side of the carotid artery, it would be a lateral neck dissection. If your cancer has not spread to a lymph node, but it is larger than 4 centimeters, it looks to be invading a nearby structure in the neck, or if you have any other concerning thyroid nodules on the opposite side of the thyroid, the contralateral lobe, then we do recommend a total thyroidectomy, removing the entire thyroid gland. If the cancer is less than 4 centimeters, and again, no signs of spreading to a lymph node, no evidence that it's invading a nearby structure on an ultrasound or CAT scan, and no concerning nodules on the other side of the thyroid, our guidelines from the American Thyroid Association say your chance of a cure is just as high if you remove one side of the thyroid or compared to removing both sides. Now, we don't ever just carve out a cancerous nodule from a thyroid gland. The reason being, if we tried that, there's a high risk of leaving cancer behind and you requiring further surgery in the future, which would be complicated by the scar tissue and inflammation from the previous surgery. Also increases your risk of injuring some nearby structures nearby the thyroid, close to the thyroid. So we would at least remove one half of the thyroid versus the entire thyroid. We do not carve cancerous thyroid nodules out. So number 1 is surgery, the way we treat well-differentiated thyroid cancers. Number 2 is sometimes you would benefit, if you require thyroid hormone medication following your surgery, which 100% of the time you would require if you remove the entire thyroid, and that's called a total thyroidectomy. If you remove one half of your thyroid, it's called a hemithyroidectomy. 30% of the time, the remaining half of your thyroid gland does not make enough thyroid hormone, and you would have to be on a once daily thyroid hormone medication for the rest of your life. We wouldn't know that until 6 weeks after your surgery. Measure your thyroid hormone levels in your blood. But if you needed thyroid hormone medication in either of those two scenarios, removing the entire thyroid gland or 30% of the time removing one half of the thyroid, our research tells us you would benefit from receiving a higher dose of the thyroid hormone medication. A higher dose of the thyroid hormone medication suppresses or lowers your TSH levels in the blood, which helps to prevent thyroid cancer from coming back and allows us to monitor for recurrence of thyroid cancer a little bit easier. So number 2 is TSH suppression with a higher dose of levothyroxine if you need thyroid hormone replacement medication following your surgery. The third way we treat well-differentiated thyroid cancers is sometimes you would benefit from additional treatment following your surgery. We do not use traditional chemotherapy or radiation like you might be familiar with other types of cancers. Instead, sometimes we consider the use of a one-time radioactive iodine pill you swallow 2 to 3 months following your surgery. Iodine is a substance that's absorbed almost primarily or only by thyroid cells in your body. Very few other cells in your body will absorb iodine. So if we were able to attach a little bit of radioactive material to that iodine, it acts like a heat-seeking missile and kills off only thyroid cells, both normal and cancerous, and lowers the risk of damaging any other cells in your body, so limits the side effects. Not everybody requires or would benefit from radioactive iodine. Only about 5 to 10% of patients would benefit from it. There are 2 pieces of objective data or information we use to determine if you would benefit from that radioactive iodine. Number 1 is the pathology report from your surgery. In that pathology report, the pathologist is looking for certain features in the cancer and your cancer that when present, we know have a higher risk of this cancer coming back in the future. We get this pathology report 2 to 3 days after your surgery. And if there were high-risk features present, we would then recommend that radioactive iodine pill. The other piece of information we use is a tumor marker level we measured in your blood 6 weeks following the surgery. This tumor marker level is called thyroglobulin, and it's a protein made only by thyroid cells. No other cells in the body make it, and we can measure it in your blood. If we've done a good job of curing your cancer or removing all of your thyroid cancer, that thyroglobulin level, that tumor marker level, should be very, very low, close to 0. If it's elevated, it's an indication that potentially some cancer was left behind by the surgeon, or potentially the cancer had spread to a lymph node, but it was too small for us to see on the ultrasound or CAT scan prior to the surgery because it was just a small seed, but we can measure it in your body afterwards. If the suspicion is that there's microscopic seeds of cancer somewhere in a lymph node, oftentimes that radioactive iodine can be effective in killing off those microscopic seeds. So a quick recap. The way we treat well-differentiated thyroid cancer is 3 different ways. Number 1, surgery. That depends on where the cancer is located. If it's in a lymph node, a total thyroidectomy and a lymph node dissection. If it's small, confined to one side with no signs that it's spreading, invading a nearby structure, we can get away with a hemithyroidectomy, otherwise a total thyroidectomy. Number 2 is TSH suppression by giving you a higher dose of thyroid hormone medication if you need it. Again, 100% of the time, if your entire thyroid has been removed, 30% of the time, just one half of the thyroid has been removed. And finally, that radioactive iodine pill, that's given 1 to 2 months after the procedure, one time, then you swallow that pill. We use 2 pieces of information to determine if you would benefit from that. Again, the surgical pathology report obtained 2 to 3 days following the surgery, and that tumor marker level measured 6 weeks following the surgery in your blood. One more note on that radioactive iodine pill. It is only effective in killing off thyroid cancer cells if the entire thyroid gland has been removed. So if you opted for a hemithyroidectomy, removing just one side of the thyroid, and either the pathology report or the tumor marker level following the surgery indicates that there's persistent thyroid cancer, you would then need a second surgery to remove the other side in order to prepare your body and allow that radioactive iodine to be effective. Once you've been treated for well-differentiated thyroid cancer, you were then followed for at least a 5-year period to make sure the cancer doesn't come back. There are 3 different ways in which you are followed. Number 1 is a physical exam, feeling for a lump or bump in the neck. Number 2 is looking deeper with an ultrasound for things that we just can't quite feel with our fingertips, deeper in the neck. And number 3 is repeating that tumor marker level in your blood, that thyroglobulin level. As long as that tumor marker level remains very, very low and stable, it's unlikely that the thyroid cancer has occurred. If the tumor marker starts to rise, that is usually the most sensitive way and the earliest way to detect if thyroid cancer has come back. Initially, you're seen 6 weeks after your surgery. If things are looking good, then either 3 to 6 months later with labs to measure the tumor marker level and ultrasound. If things look good at that appointment, then usually yearly with labs and ultrasound until we get to a 5-year period. If there's no evidence the cancer has come back at the 5-year period, then we would say you're clinically cured. If there's any other suspicion, mild suspicion there could be some cancer present, then we would continue to watch you longer. At any point in time during that 5-year period, it is possible for the thyroid cancer to come back. If it were to come back, typically it was in a lymph node or spread to a lymph node that we had not noticed prior to the surgery. And with time, it grew to the point either we could measure it in the blood or see it on an ultrasound. In that situation, the best way to cure that recurrence or return of the cancer is with surgery to remove that lymph node and all the rest of the lymph nodes in that compartment. Oftentimes, we can still cure a recurrence of thyroid cancer, a very well-differentiated thyroid cancer, at a very, very high rate. Sometimes, very rarely, the cancer can come back into a lymph node of the neck and start behaving aggressively where it would invade a critical structure in the neck, like your windpipe or your carotid artery, which could then become life-threatening. And very rarely could it spread beyond your neck to your chest or other places in your body. At that point in time, it would be impossible to cure that cancer. So that's our talk on well-differentiated thyroid cancer. For any more questions about well-differentiated thyroid cancer or other types of thyroid cancer or any topic on thyroid or parathyroid glands, please visit my website at sethkaymd.com. That is SETHKAYMD.com. Thank you very much for watching.